The title of our poster is Idiopathic Intracranial Hypertension, a Headache to Treat. Idiopathic intracranial hypertension is a condition with no known pathogenesis that is best characterized by signs and symptoms of raised intracranial pressure. Elevated opening pressure during a lumbar puncture greater than 20 centimeters of water in non-obese patients or greater than 25 centimeters of water in obese patients establishes the diagnosis. Although the clinical presentation is highly variable, some common symptoms include headache, visual disturbance or loss, pulsatile tinnitus, neck and back pain. A timely diagnosis and treatment are important in preventing visual morbidity. Management of symptoms like headache can be challenging since pathogenic mechanisms remain unclear. Commonly suggested mechanisms for increased ICP include CSF hypersecretion at choroid plexus, reduced drainage across arachnoid granulations, venous sinus stenosis causing increased venous sinus pressure, and increased thoracic pressure raising the venous sinus pressure. Therefore, a significant therapeutic area of focus has been dysregulation of ICP with surgical interventions, such as venous sinus stenting, CSF diversion with shunts, and optic nerve sheath fenestration. In patients with mild visual loss, there is class 1 evidence for the use of acetazolamide with a low-salt diet to improve visual symptoms. Case description. A 36-year-old with ESRD due to IgA nephropathy on hemodialysis, hypertension, irritable bowel syndrome, GERD, fibromyalgia, and idiopathic intracranial hypertension presented with worsening headache, nausea, and vomiting since successful angioplasty and stenting of the severely stenotic segment of the right dominant transverse sinus to address IIH a few days prior. Patient described severe throbbing right retroorbital pain with and without ocular movement, sonophobia with robotic echo, and frequent intense headaches similar to when first diagnosed with IIH in 2015. She also reported worsening blurry vision in both eyes. CT head showed good stent positioning and flow. For her headaches, she had tried topiramate, tramadol, NSAIDs, Diamox with no significant improvement. Prior to stenting, the patient had undergone serial lumbar punctures for elevated intracranial pressures with most recent open pressures of 51 centimeters of water, 38 centimeters of water, but strangely, on the day of admission, her pressure was greatly improved at 21 centimeters of water. Ophthalmologic examination showed bilateral optic disc edema and pallor with visual field defects. Acetazolamide treatment was discontinued due to concerns about toxicity and relative contraindication in ESRD. Since hemodialysis has been identified as a possible cause of central venous stenosis or obstruction leading to IIH, a CT chest venogram was performed to assess for central venous stenosis. The superior cavo-atrial junction was found to be diminutive in caliber, measuring down to 1.8 times 0.8 centimeters in transaxial dimensions, suggesting central venous stenosis. Patient underwent angioplasty of the superior vena cava with a correction of pressure gradient from 6 millimeters of mercury to 14 millimeters of mercury with no hemodynamically significant residual stenosis. Patient continued to have refractory headaches with right retroorbital pain and blurred vision, with migraine-like features of photophobia and sonophobia. Abortive treatment with toradol, Benadryl, compazine cocktail, and sumatriptan were unsuccessful. Patient was also started on nortriptyline and vitamin B2 daily for headache prevention, and empirically treated with Medrol dose pack for 5 days with no significant improvement in headaches. The image below is a cerebral angiogram. The figure A is the cranial segment of the right ICA can be seen to be normal. The right MCA and right ACA are also normal. The venous phase demonstrates a dominant right transverse sinus with severe stenosis at its lateral aspects, where the arrow is pointing. In figures B and C, post-stenting right ICA angiogram can be seen. The stent is noted in the lateral aspect of the right transverse sinus with complete resolution of the transverse venous sinus stenosis. Discussion. Despite exhaustive treatment modalities, including medications and surgical interventions, such as stenting of transverse venous sinus stenosis and angioplasty of central venous stenosis, our patient's symptoms of retroorbital pain and atypical right-sided headache persisted. This case illustrates that a refractory atypical headache in some patients could be due to IIH or related to some other underlying pathology, such as migraines or fibromyalgia. A link between migraine and idiopathic intracranial hypertension, as well as a shared common pathophysiologic pathway with fibromyalgia, have been suggested without evidence. Further research is needed to shed light on refractory symptoms of IIH in the context of underlying pathologies like fibromyalgia. Thank you.